I am an ophthalmologist. I actually did a fellowship in glaucoma, and I've been in practice here in the Quad Cities for the last 23 years. I see all types of patients, but I would say 70% of my practice is glaucoma. But when it comes to surgical ophthalmology, I would say the large bulk of my procedures are either cataracts or cataracts with minimally invasive glaucoma procedures. And then I also do other types of glaucoma procedures as well. And I do about 110 to 120 procedures at the surgery center on a monthly basis. And I've been at the surgery center for a good 15 years.
I've served as the administrator here at Spring Park for nearly 10 years. We're a multi-specialty surgery center. We specialize in ophthalmology, urology, and pediatric dentistry patients. We were the first ASC to open its doors in the state of Iowa in 1986, which is a huge feat for us. As administrator, I oversee about 50 clinical and non-clinical staff, as well as responsible for the daily operation of the ASC. This year, we're going to be doing a record number of cases, which is a huge thing for us, about 7,200 cases, 4,300 of which are cataracts. So all 6 of our cataract surgeons are using OMIDRIA. We've been going strong with complete surgeon implementation since December 1st of 2015. As for changes, if you remember, we started as a C code and it has evolved into a J code. And that's huge. And I believe Dr. Wagle and I were a big part of that because we were part of the conference calls. We wrote letters, we sat in on Zoom calls, we spoke to our state senators, you name it. To date, from what I'm being told, we're the #1 ASC in the Midwest that are utilizing OMIDRIA.
All of our surgeons use OMIDRIA, and I use it on almost all of my cases. The only cases that I don't use it on is if there is a contraindication to using it, in which case then I put epi in the bottle, but otherwise we use OMIDRIA. I have been extremely happy with it because of the merits that it has. It certainly does help keep the pupil dilated throughout the entire case. It prevents intraoperative miosis in the bulk of cases. And it also does help with any ocular pain that patients may be experiencing either intraoperatively or even postoperatively. I initially started using it when we implemented it in December of 2015, and I have not gone back. I think that it has just really allowed my cases to be a lot more predictable. And I just have that assurity that during the entire case, I know that the pupil will be dilated. As we're continuing to do more and more premium lens cases as well with femtosecond laser and other types of intraocular lenses, such as presbyopia correcting lenses, toric lenses, light adaptable lenses, it's very important for us to have a seamless case as much as possible. And the nice thing about OMIDRIA is that the phenylephrine will keep the pupil dilated, and then the ketorolac will also allow for significant COX-2 inhibition through the entire case to minimize some of that inflammatory cascade, which ultimately leads to pupillary miosis. And so the combination of the two has really been second to none in keeping the pupil dilated and allowing for a seamless cataract surgery. Definitely we see less. As I'm sure you probably know, when the pupil starts coming down at the time of cataract surgery, for every 2.5 millimeters of pupil miosis that occurs, you lose over 50% of your operative field. And that just makes for a much more challenging case. You can get through the case if you're an experienced surgeon, but sometimes you have a very hard time. And so when you have that assurity that that pupil is going to stay dilated through the entire case, you just have a greater scope of field, and therefore that leads to less complications during the case. We do a lot of patients who have glaucoma, which sometimes they can be on chronic eye drops. Some of them can make the pupil small, and therefore they don't dilate as well. When you add OMIDRIA, it can keep that pupil at a fairly good diameter. In addition, we have a lot of people who are on alpha blockers, such as Flomax and medicines similar to that. And when we have Flomax patients, we always worry about intraoperative floppy iris syndrome. And so OMIDRIA has really been instrumental, at least in our facility, in keeping the pupil dilated, preventing some of the iris billowing that occurs. And it actually has decreased our use of pupillary expanding devices significantly in our surgery center because of the use of OMIDRIA.
Absolutely. You have to weigh the costs of the alternatives against the new technology. So OMIDRIA, as Dr. Wagle has indicated, has reduced our center's use of non-reimbursed Malyuginin rings by 35%. By switching to simple lidocaine numbing drops for most patients instead of the lidophenol drops, we save nearly $20 in supply costs per case. And then we cut back the time and supply it took for staff to draw up meds on each cataract day, which results in savings. So absolutely, hands down.
Since we've implemented OMIDRIA, we have not dropped our topical NSAID, but we are only using a once a day NSAID, and then we do use Dextenza as well on patients, and therefore, if we do use Dextenza, then they do not use a steroid component post-operatively. We also do intracameral Vigamox at the end of the case, but we still use an antibiotic post-operatively. We do have less incidences of cystoid macular edema post-operatively. And the thought is that with that ketorolac being infused throughout the entire case and the significant COX-2 inhibition that it's providing, or COX-1 and 2 inhibition that's providing, maybe there's less prostaglandin release at the time of surgery, which ultimately could lead to less rebound inflammation post-operatively and less cystoid macular edema post-operatively as well. And so that's the other added benefit that you have of using OMIDRIA, is that it could help to decrease some of these post-operative issues that can occur in some patients.
You really need to sit down and weigh the intangible benefits of having your latest technology, such as being perceived as cutting edge, generating referrals, or attracting more surgeons to the ASC. It's no different when it comes to OMIDRIA. The administrators, we need to do our research. When I went back to the surgeons in 2015, I said, hey, look, there's this drug we can use in cataract surgery. And then I rolled it out to them. I had buy-in from them. I had buy-in from the board. And surgeons need to believe in this product. If they don't believe in it, you're not going to have anyone use it. For us, using OMIDRIA was a no-brainer. OMIDRIA has clearly demonstrated its ability, both in the hands of our surgeons and in published studies, to improve outcomes and reduce complications for cataract surgery patients.
I think the most important thing is to get buy-in from the surgeons, as Heather mentioned. It is very important because any type of device or therapeutic is not going to be successful if the physician doesn't believe in it. I was convinced within the first couple of weeks of using it on how instrumental this was in allowing for the people to stay dilated. But one of the stories I can share with you is one that happened a couple of years ago, where one of I had a long surgery day, about 20 cases, and I remember I did one case in the middle of the day, and in the middle of the case, the pupil started to come down fairly small, like to almost 2.5 to 3 millimeters. I struggled through the case. It ended up delaying the rest of my day. I got through the case okay. I was able to put an implant in, but of course, it was definitely a more difficult case because the pupil had come down so small. At the very end of that day, my circulator and my circulating nurse in that room was doing some checkup procedures, and she came up to me and she said, Dr. Wagle, I have something to tell you. And I said, what's going on? And she said, I realized that there was one patient that I did not put the OMIDRIA in the bottle in. And I was like, really? And she's like, yeah, I'm really sorry about that. I don't know how it happened, but I can tell because I have this leftover bottle, so I must not have put it in a patient. And I know now exactly which patient this was. And right away I said, don't tell me, I'm going to tell you, was it this patient? And I mentioned the lady that I was having a problem with. She goes, yes, that was a lady who I forgot to put it in. And of course I said, yeah, I could tell because she had a pupil that came down. Well, a couple of weeks later, I did her second eye. I made sure that OMIDRIA was in the bottle. I did that case. The entire case went smoothly. The pupil stayed dilated throughout the entire case. And it was as if nothing happened on the first eye. And so that, to me, really helped convince me even more that OMIDRIA is something that should be used in all cases. In 25% of cases, you can get intraoperative miosis with no risk factors at all. And that's about a quarter of people's cases. And that's a significant number. And so for me, OMIDRIA, if it can help reduce that number to a much smaller percentage, that's convincing enough for me. And the best thing about this product is that it is a pass-through in a surgery center. You do get reimbursed for it, and it makes for a much better patient experience with less risk of complications. And anything that's going to reduce my risk of complications, I feel is something that I need to try and implement in my cataract surgery protocol.